Okay. So the first case is a urine specimen from a 64-year-old female. The patient has presented at our outpatient clinic with hydronephrosis, and the image suspect there is obstruction. Here is her voided urine specimen. So we talk about urine specimen, voided urine specimen. So on low power, we do see individual urothelial cells, and we can appreciate that they are umbrella cells. Some might be the contamination of the gynecologic tract with some keratinized cells. And then we start to see scattered cells with enlarged nucleus, and on this power you can tell that the chromatin pattern is darker than the adjacent normal urothelial cell nucleus. In addition, the cell does has an increased NC ratio, so this cell looks quite suspicious. So we see one over here, then another over here. Then we take a closer look, so we are now on higher power. You can start to appreciate that the chromatin pattern is actually different than the coarse chromatin pattern. That you can see there's sort of like a material which does not stand, so showing this ground glass appearance and pushing all the chromatin to the periphery of the nuclear membrane with this membranous attenuation, not attenuation, like a membranous, like a marginalization. So this nucleus looks ground glass. So whenever we see a large cell with a high NC ratio with ground glass chromatin pattern, we think about that it could be virus inclusion. The most common virus inclusion would be polyoma virus. So you need to tell the subtle difference between a true, like a coarse chromatin versus this type of ground glass chromatin with peripheral margination. So this cell does look atypical. However, because of the chromatin pattern, it looks more like what we call a decoy cell. A decoy cell, which means that a virus inclusion cell mimicking a high-grade urothelial carcinoma. So we call this decoy cell. Usually, when we see virus inclusion, we would expect the patient to have some immunocompromised condition. For example, if the patient is a transplant patient who underwent immunosuppression, or the patient is a cancer patient that undergoes some chemotherapy. So the patient has past history of ovarian cancer and has been treated, but she hasn't been treated for a couple years, possibly for 2 years. So it is a little bit difficult to make judgment whether these are representative of true virus inclusion or these are actually kind of like a typical cell. And given her like a current situation is hydronephrosis, there was still a chance that there might be some lesion in the ureter, in the urinary tract. However, hydronephrosis can also be caused by the chemoradiation therapy for the GYN cancer after the treatment, causing fibrosis and hydronephrosis. So it's a little bit difficult to tell. So we call this case atypical. But we mentioned that polyoma virus inclusion should be considered. Yeah. In rare occasion, we will sometimes see some healthy patient with a urine specimen showing typical decoy cells. In that situation, usually in elder patient, we would ignore that and we won't report it. We would just call this negative urine specimen. However, because the patient is a cancer patient, It's possible that this could be viral inclusion, but because the treatment has been completed for a while, and her current clinical symptom, we would call this atypical. But we make a comment that it can be polyoma virus inclusion. So let's move to the other body fluid. So we have a CSF specimen. In the normal CSF, there should not be any cells. So whenever we see a CSF specimen, it is totally acellular. We will call this negative. This patient has a past history of lung adenocarcinoma and is suspect to have leptomeningeal spreading. So we see very scattered cells with cohesiveness. And again, the cells show typical cytomorphology of a fully differentiated adenocarcinoma, which is enlarged nucleus, prominent nucleolus, and with eccentric location and intracytoplasmic vacuole. And most of the time when we see metastatic adenocarcinoma in the CSF, it presents with individual cell. However, in this case, it does form tight cluster, suggests that it is epithelial origin. And so this is positive for metastatic adenocarcinoma. So metastatic adenocarcinoma is one of the most common positive specimen type in the CSF. The second CSF case is from a 30-year-old male. So because this is a cytospin preparation, sometimes with a scan cellularity specimen for the cytospin, it will show an artifact of like a configuration artifact that most of the cell flow out of the circle. But you can still appreciate that at the periphery of the circle, there are some cells with good preservation of cytomorphology. So here we see individual cells with very high NC ratios. The nuclear size is not very big. It's about medium size. But the NC ratio is really, really high. The chromatin pattern, if you pay attention to the chromatin pattern, this like loosely clumped chromatin pattern. So this cell looks like lymphocytic cell. So we have a CSF specimen with predominant lymphocytic component. However, these lymphocytes does looks atypical. The size is bigger and the chromatin is much more open than the reactive type of lymphocyte. So we check the patient's history. The patient does have past history of acute lymphoblastic leukemia of B-cell lineage. So this is the second most common type of CSF, positive CSF specimen, which is lymphoma leukemia involvement of the CSF. So this is positive and compatible with the acute ALL involvement. So let's move to some other more common specimen. So this is a pleura effusion specimen. The patient has past history of lung adenocarcinoma. So on low power, we see some proteinaceous background and we see a lot of inflammatory cells. However, we does see small but tight cluster forming these small cell ball, three-dimensional architecture scattered throughout the entire specimen. So these are the guys that we are going to look on higher power. And then you start to appreciate that these cell cluster is very three-dimensional. You have to adjust your focus to see through, see clear every cells in different levels. And when you take a look of the individual cell morphology, the nucleus is very irregular is much bigger than the adjacent lymphocyte, the cytoplasm show vacuolation. So these overall represent an adenocarcinoma, and this is positive and compatible with the recurrence of the patient's past history of lung cancer. So these tight cluster can like trap in the clotting or in the proteinaceous material, but still maintain the identifiable features of adenocarcinoma. So this is positive for recurrence of adenocarcinoma. So the next specimen is ascites specimen from a 70-year-old male. So this is relatively challenging. So on low power, we see again some like a debris proteinaceous material with a lot of single cell with high nucleus entrapped into it. So the single cells does looks like lymphocyte. However, the background seems to be pretty necrosis, and all these lymphocytes looks a little bit atypical. The size is bigger. So if this is a size of reactive lymphocyte, this apparently is much bigger. So this is reactive. These guys are atypicals. So we have a lot of atypical lymphocyte with a very necrotic background. And this is a new patient presented with massive ascites. So we've seen the specimen yesterday, but after the slide meeting, because the patient is a little bit like urgent, so we signed out the case. Dr. Shi has already ordered some immunostat for this case, and the cells are positive for CD20. So these represent a typical lymphocyte with B cell lineage and with massive necrosis. So this is most likely a high-grade lymphoma. So when we think about the high-grade lymphoma, in the body fluid, there were several possibilities. The most common scenario would be an involvement of a nodal lymphoma. So usually the patient should present with enlarged lymph nodes. So based on the image study, the patient does have multiple enlarged lymph nodes in the retroperitoneum. So this is likely, most likely the involvement of the nodal lymphoma, and this is represent the high-grade B-cell lymphoma. And without any treatment, sometimes the patient coming from the other hospital was referring from the other hospital has already been treated with steroid. So after steroid treatment, the lymphoma cell can has marked degeneration presented with massive necrosis. So this is one of the possibility. The other possibility is that the lymphoma itself is highly proliferative, and so that's cause a lot of necrosis. And the most famous lymphoma would be a Burkitt lymphoma. So these are all the possibility. However, we cannot make very good classification only by the effusion specimen. So we would call this again positive for malignant lymphoma, and the clinician need to do a biopsy to have proper classification of the lymphoma type. So for the body fluid specimen, we commonly perform an additional cell block preparation. So this is the cell block of the same case, and you can appreciate that in the background it does has a lot of necrotic debris proteinaceous material. And this is the specimen that we can use for the immunohistochemistry. So finally, let's take a look at fine needle aspiration. The first case is from a 56-year-old female presented with thyroid multinodular goiter, and she has received radiofrequency ablation, and there is a different nodule. So this is the nodule that the clinician sampled. So as we discussed yesterday, the fine needle aspiration usually is focusing on the lesion. So supposedly you will see the lesional component. In the normal thyroid, we expect to see normal follicular cells as well as some colloid. However, in this specimen, we didn't see any follicular cells. So we only see these benign-looking squamous intermediate cells, as well as some inflammatory cells, which is kind of strange. So it does not demonstrate the normal component as the clinical suggested. So there can be some like a possibility. The first possibility is that can this be a contamination from the skin? The other possibility is that can the clinician just make a mistake on the location? So now we have seen more than, I think this is the 5th case of like this days, and then we see benign squamous cells, and then we start to see, then we start to see some plant component. So this is vegetable. So this is the vegetable that the patient eats. And then we start to see, we see inflammatory cells. We see these debris. And I think this is represent a starch particle. So we see food content, we see benign looking squamous cells. So these most likely is pharyngoesophageal pouch or diverticulum protruding from the trachea into the thyroid. So I checked the sono, it does look like that. It also has a well-formed muscular layer under the sonograph. So we would not use the Bethesda system to report this case. We will call this other aspiration. It's negative, and we see benign squamous cell and food particle, which is compatible with pharyngoesophageal diverticulum, and the site was labeled as thyroid nodule. So this is how we going to report the case. 我们是不是原本有个60倍的，怎么不见了？装到那边去。哦，好。So the final case is also a very interesting case. This is parotic aspiration. So on low power, the background is pretty clean, and we do see a lot of cellular fragments, so the specimen is diagnostic. Then we start to see some loosely stained, like amorphous material. These are so-called chondromyxoid matrix. So we do see chondromyxoid matrix admixed with some spindle cells. So these spindle cells are myoepithelial cells producing this matrix. So we have chondromyxoid matrix, we have spindle-looking myoepithelial cells. Some myoepithelial cell can be more epithelioid, more rounded with a plump, like features, and sometimes with plasmacytoid arrangement. So these are all myoepithelial cells. So this looks like a pleomorphic adenoma. So sometimes we will also see some ductal components. So here are some ductal components which constitute the major three component of a polymorphic adenoma, which is myepithelial cell, chondromyxoid matrix, and duct. So this is a very typical case of a polymorphic adenoma. So whenever we had a specimen of a polymorphic adenoma, we will usually do a very thorough search to see if we have any evidence of high-grade transformation, or what we call carcinoma X polymorphic adenoma. So in this specimen, we does has a few cluster of cells already exceeding the atypical, like a reactive type atypia of myepithelial cell or ductal cell. So this cluster, if I don't tell you the location, this looks like high-grade adenocarcinoma. So we have one area over here. We have another area over here. Here is even more clear because you have a clear contrast with the benign looking myepithelial cell over here. And this one, the nucleus, is gigantic, and you can appreciate the polymorphism and like a variation of the distance between these nucleus. So this also looks high grade. And also here. So here we've seen some non-neoplastic acinar cell represents as a benign parotid, like a parenchyma. We also see like a ductal cells over here. However, we also see a bigger fragment of like a much more atypical looking cluster over here. So for this case, we know it is a polymorphic adenoma, but because of these tiny cluster with high-grade morphology, we would suspect that it already developed the high-grade transformation or carcinoma malignant transformation. So we go back to the patient's past history. The clinical note suggests that he presented with a rapidly grows mass, so which is also compatible with the clinical presentation. Because of the scant high-grade component, we call this case as Milan category 5, suspicious for malignancy, and we make a note that we see highly scant, highly atypical cells in the background of polymorphic adenoma, and suggests it can be a carcinoma X polymorphic adenoma. So the clinician will do further management based on our diagnosis. So these are all the cases for today. Thank you.